Hello everyone and welcome to this strategic presentation on the architecture of medical assessment. My name is Associate Professor Dr. Latt. Today we are going to explore how medical education is undergoing a profound paradigm shift, moving from traditional single point in time written examinations toward comprehensive competency-based evaluation frameworks. We will look closely at how we design assessment that balance knowledge, practical clinical skills, and professional attitudes to guide a learner smoothly from a novice student to a fully competent independent expert. Assessment is not merely about grading students, it is a strategic process that ensures future healthcare professionals possess the knowledge, skills, and professional attitudes required for safe patient care. Throughout this presentation, we will examine how assessment methods have evolved, why multiple assessment tools are necessary, and how modern medical education integrates different methods to produce competent graduates. For example, think of this transition like learning how to drive a car. Traditional education just checks if you can pass a written rules of the road test. Competency-based education, however, ensures you can accurately steer, park, and safely navigate a busy highway during a rainstorm before giving you the keys. Whenever we design or evaluate an assessment method, we must balance four fundamental forces. First is validity. Does the test accurately measure what it is supposed to measure? Is it aligned with our learning outcomes? Second is reliability. It is the test consistent. Would a student get the same score if they were evaluated by a different examiner or a different day? Third is the feasibility. Is it practical? Do we have the financial budget, the physical equipment, the time, and the faculty bandwidth to implement it? And fourth is acceptability. Do our students and faculty members embrace it is fair, educationally useful process? When selecting an assessment method, four major factors must be balanced, like validity, reliability, feasibility, and acceptability. Validity asks whether the assessment measures what it is intended to measure. Reliability refers to consistency of results. Feasibility considers time, cost, and resources. Acceptability examines whether stakeholders view the assessment as fair and useful. For example, an OSCE may have high validity for clinical skills but require significant resources affecting feasibility. For example, imagine using a standard weighing scale to measure a patient's height. The scale is highly reliable because it will give you the exact same number every time you step on it. However, it completely lacks validity because a weighing scale cannot measure height. Every tool we must use achieves both consistency and accuracy. This slide illustrates a reality that no assessment method is perfect. Improving one characteristic may reduce another. For instance, workplace-based assessment may increase authenticity and validity, but reduce reliability due to assessor variation. Written examinations are highly reliable, but may not fully assess real clinical performance. Medical educators must therefore make informed compromises based on educational goals. In a perfect world, every assessment would be 100% valid, reliable, feasible, and acceptable. In reality, we face a major trade-off. Look at this reader chart. A standard written multiple choice question or MCQ exam is incredibly high in feasibility. You can print 100 copies or host it online and it grades itself instantly. However, it is low in direct clinical validity. On the flip side, a high fidelity clinical exam with real patient is exceptionally high in validity. It tests real clinical performance. But its feasibility drops significantly because it requires massive resources, coordination, and faculty time. As educators, our key insight here is that high-fidelity clinical exams intentionally sacrifice feasibility in order to capture true clinical validity. For example, giving a student or MCQ about how to suture a wound is highly feasible. You can test 200 students simultaneously in an hour, but it doesn't prove that they can hold a needle. Having them accurately suture a laceration under examiner supervision takes hours and costs money, but it is the only way to validity test the skill. Medical education evaluates learners in three domains: cognitive, psychomotor, and affective. The cognitive domain includes knowledge and critical thinking. The psychomotor domain includes procedural and clinical skills. The affective domain encompasses attitudes, professionalism, ethics, and communication. A competent doctor must perform effectively in all three domains, making multidimensional assessment essential. To build a holistic medical professional, we must target three educational domains. The first is the cognitive domain, which covers medical knowledge. It climbs Bloom taxonomy from simple remembering up to complex evaluation and creation. It is the easiest to reliably scale up, boasting an average 95% reliability rate with a very low resource cost. Next is the psychomotor domain, which focuses on hands-on clinical skills. It progresses from basic imitation to complete naturalization. This requires direct observation using tools like OSCE or simulations, pushing the resource cost up significantly while maintaining a strong 75% reliability index. Finally, we have the affective domain, dealing with professional attitudes, ethics, and communication. This is the hardest to measure objectively. It has a lower reliability index of around 40% because of social desirability bias, meaning students often act the way they think we want them to act rather than how they would normally act when no one is watching. Evaluating this domain requires continuous long-term observation. For example, think of a cardiologist. They must know the physiology of a heart attack. It is cognitive. They must know how to physically insert a cardiac catheter smoothly. This is a psychomotor domain. But they must also break devastating news to the patient's family with empathy, honesty, and professional composure. That is the affective domain. Our key strategic takeaway from this architecture is simple. To graduate a safe clinician, we must intentionally design an assessment metric that balances all three columns because a breakdown in any single domain compromises patient safety. In the real-world example, like think about an orthopedic surgeon preparing to perform a complex hip replacement. First, they must possess the deep anatomical knowledge to plan the surgery and avoid major blood vessel, that is the cognitive domain. Second, they must have the precise tactile hand-eye coordination to position the implant perfectly, that is the psychomotor domain. Third, if an unexpected complication occurs or an error is made, they must have the honesty, transparency, and communication skills to explain the situation ethically to the patient's family. That is the affective domain. A flaw in any of these three areas makes the surgeons unsafe. This slide demonstrates how assessment methods align with Bloom's taxonomy and the assessment pyramid. Knowledge forms the foundation, followed by skills and attitudes. As students progress from basic understanding to independent practice, assessment methods become more authentic and complex. For example, early students may sit written examinations, while senior students are assessed through OSCEs, workplace observation, and portfolio evidence. To visually tie these domains together, let's look at the George Miller's classic assessment pyramid. At the absolute foundation of clinical competence, we have knows and knows how. This represents core cognitive knowledge typically evaluated through standard written tests. As we move up to the third tier, we hit shows how. This is where competence is demonstrated in controlled simulated environments, such as objective structure clinical examination or OSCE. At the very peak of the pyramid sits guess. This is true professional performance, how the medical trainee actually behaves when they are independently managing real patients in the day-to-day workplace. As you can see, we ascend from the base to the peak. The resource intensity climbs drastically, but we get closer to evaluating real-world capacity. For example, a student knows the antibiotics for pneumonia. They know how to calculate the correct dosage based on renal function. They show how to explain this treatment plan to a simulated patient as an exam room. But the peak is what they actually do on chaotic night shift in the emergency department when managing 5-6 patients at once. Let's take a look back at our traditional roots, written and oral exams. Written tools like MCQ, short answer questions, and essays are incredibly useful for measuring a broad knowledge base across hundreds of students simultaneously. However, their limitation is that essays suffer from highly subjective grading and poorly written MCQs can accidentally promote superficial rote memorization. The fix: we must implement highly structured marking rubrics for essays and rigorously train our faculty to build high-quality blueprints for MCQs. Now, let's look at the oral exam. Their core strength is that they allow an examiner to probe deeply into a student's clinical reasoning, but the limitation is severe. They are highly subjective, prone to personal examiner bias, and induce extreme anxiety in students. To fix this, we must transition to structured vivas that utilize standardized question banks and mandate multiple examiners to dilute any individual bias. For example, in an unscripted oral exam, one examiner might be friendly and ask an easy questions about high blood pressure, while another examiner might be tired and ask rare questions about a genetic metabolic disease. That inequality is what we mean by examiner bias and lack of standardization. The variability flaw in traditional clinical exams. In our traditional clinical examinations often suffer from inconsistency. Different students encounter different patients, examiners, and clinical scenarios. This lack of standardization reduces fairness and reliability. One student might receive a straightforward case while another faces a highly complex patient. Such variation prompts the development of more standardized assessment approaches. For generations, the long case and the short case clinical exams were the gold standards. While they are great for observing real-life patient interaction, they suffer from a major structural flaw: patient and case variability. Here is the breakdown of why the system can fail. No two real patients are identical. One student might draw an incredibly cooperative patient with clear classic clinical signs. Another student might draw a patient who is in pain, uncooperative, or has a highly complex, confusing medical history. This random variation drastically lowers the reliability of the exam. When you compound patient variability with subjective examiner grading, the fairness of the test crumbles. Our structural fix is clear. Institutions must actively shift toward utilizing trained standardized patients and implementing highly structured grading checklists. This requires strict patient selection and careful examiner calibration before the exam begins. For example, imagine two students taking a driving test. Student A takes their test in an empty parking lot on a sunny day. Student B takes their test through downtown traffic during a thunderstorm. You cannot fairly compare their scores because the difficulty of the environment was entirely unstandardized. This brings us to the modern revolution. So competency-based medical education or CBME. In the past, assessment was a single point in time, high-stakes harder. It was highly variable, subjective, and focused heavily on memorization. Traditional assessment established a vital knowledge foundation, but they were far too limited in clinical scope and reliability. The future demands standardized testing environments, continuous formative feedback loops, real-world clinical context, and holistic assessment frameworks. Modern assessment bridge these old structural gaps to measure accurate real-world clinical competence rather than just test-taking stamina. For example, instead of judging a resident's entire surgical capability on one massive, terrifying final exam at the end of the year, that is the PUS. Now, CBME tracks their performance across dozens of surgeries throughout the year, giving them immediate feedback to correct errors in the real time. That is for the future. The OSCE was introduced to improve fairness and reliability in clinical assessment. Students rotate through standardized stations where each candidate performs identical tests under similar conditions. Examples include history taking, physical examination, counseling, and interpretation of investigations. Structured checklists and trained examiners increase objectivity and reduce bias. How do we standardize clinical skills successfully? We use OSCE. This is a massive win because it completely eliminates patient's variability. Every single candidate rotates through the exact same series of time stations. For example, a candidate spends 10 minutes taking a history at station 1, moves to station 2 to perform a physical exam, and then moves to station 3 to practice patient counseling. Because the scenarios and the standardized actors are identical for everyone. Reliability and clinical skills validity are exceptionally high. However, we must acknowledge the cost. The OSCEs are incredibly resource intensive. They require meticulous blueprinting, intense logistical planning, large spaces, and extensive training for simulated patients. Furthermore, it is still an artificial simulated setting. For example, in an OSCE station focusing on asthma counseling, every student interacts with the exact same actor, who is trained to give the exact same medical answers and display the exact same level of anxiety. This ensures that the student is graded solely on their communication skills, not on the lack of the draw. Clinical competence ultimately must be demonstrated in real practice settings. Workplace-based assessment allows supervisors to observe learners interacting with actual patients. These observations provide valuable evidence about clinical reasoning, communication, teamwork, and professionalism. The challenge lies in ensuring consistency among assessors while preserving authenticity. To reach the very top of Miller's pyramid, we must assess trainees directly in the workplace using workplace-based assessment or WBBAs. Our core tool is include the mini CAX, mini clinical evaluation exercise or DOPS, direct observation of procedural skills, and CPD, case-based discussion. The value proposition of WBPA is immense. It immerses evaluation in the authentic context of everyday patient care. It completely eliminates point-in-time cramming, replacing it with a continuous formative feedback loop that is essential for CBME. Of course, there is a structural challenge. Clinical faculty face severe time pressures while managing busy wards, and variation in SSR engagement can limit its effectiveness. We overcome this hurdle by mandating faculty development workshops and embedding user-friendly digital grading forms directly into daily hospital routines. For example, during a routine hospital round, a senior consultant stands back and spends 50 minutes observing a resident consents a real patient for a blood transfusion, as like mini CX. Immediately afterward, they spend 5 minutes giving concrete feedback on what went well and what needs improvement. That is the workplace-based assessment in action. As I mentioned earlier, WPBA includes mini CX, direct observation of procedural skills, case-based discussion, and multi-source feedback. These tools provide real-time evaluation during clinical practice. For example, a supervisor may observe a student performing venipuncture and provide structural feedback immediately afterward. WPBA emphasizes learning and improvement rather than solely judging performance. Simulation-based assessment provides safe opportunities to evaluate high-risk clinical skills. Learners can manage emergencies such as cardiac arrest, trauma resuscitation, or airway obstruction without endangering patients. Simulation allows deliberate practice, immediate feedback, and repeated exposure to rare scenarios. This approach is particularly valuable in patient safety initiatives. The advantages are clear. Simulation labs provide a perfectly safe, controlled environment where high-stress clinical scenarios can be fully standardized and repeated over and over again until the learner achieves absolute mastery. The clear limitations, however, are that simulation labs are highly expensive to build and maintain, and they can sometimes lack psychological realism. To fix this, we must utilize rigorously validated scenarios and integrate simulation seamlessly into actual clinical training. This training is scheduled to guarantee that these high-fidelity skills transfer directly to real patient outcomes. As an example, think of how commercial airline pilots train. They don't predict recovering from a catastrophic engine failure with 300 real passengers on board. They use high-fidelity flight simulators. In our medicine, we use advanced mannequins to test how a team handles sudden cardiac arrest or a severe postpartum hemorrhage in a safe environment. How about the portfolios and reflective practice? Professional development occurs over time rather than an isolated event. Portfolios and reflective practice help capture this growth. Students collect evidence of achievement, reflections, feedback, and learning plans. For example, a learner may reflect on a challenging patient interaction and describe strategies for improvement. Such evidence supports assessment of professionalism and lifelong learning. A portfolio is a longitudinal collection of a learner's work, reflections, and feedback over time. The immense value here is that it shifts over focus from a single exam to continuous programmatic assessment. It tracks growth, identifies pattern or weakness clearly, and forces the students to engage in self-reflection. What are the challenges? The portfolio can be incredibly overwhelming to grade, and if not structured well, students might treat them as a superficial box-checking exercise. To fix this, institutions must implement user-friendly digital e-portfolios and assign dedicated mentors who meet regularly with students to review their progress. The comprehensive assessment diagnostic matrix shows no single assessment method can evaluate every competency. This matrix demonstrates how various tools complement one another. Written examinations primarily assess knowledge, OSCE assess clinical skills, WPBA captures real-world performance, and portfolio evaluate reflection and professionalism. Using multiple methods creates a richer and more defensible assessment system. The programmatic assessments integrate multiple low-stakes assessments collected over time. Instead of relying on a single high-stake examination, decisions are based on numerous data points. Feedback becomes central to learning. This approach improves educational decision-making and provides a more comprehensive picture of learner competence. Formative assessment supports learning by providing feedback without major consequences. Summative assessment evaluates achievement and contributes to progression decisions. Effective programs balance both functions. For example, practice OSCE may be formative, while final professional examinations are summative. Together, they promote learning and accountability. Historically, assessments were strictly summative, meaning that they occur at the very end of the semester purely to grade the student. This is known as the assessment of learning. Modern medical education demands that we pivot toward formative assessment or assessment as learning. The assessment itself should be a powerful educational tool. When a student takes an exam or undergoes a workplace observation, the immediate feedback they receive highlights their cognitive gaps and shapes their future study habits. In short, what we test and how we test it completely drives students' behavior. If we only test memorization, they will only memorize. If we test clinical reasoning and empathy, they will predict clinical reasoning and empathy. As an example, if a resident undergoes a weekly formative quiz on radiology images and immediately sees an exception of why their diagnosis was wrong, that test wasn't a hurdle to penalize them. It was the exact tool that taught them how to read their X-ray correctly next time. Assessment should align with learning outcomes, teaching activities, and curriculum goals. This principle is known as the constructive alignment. Feedback serves as the bridge connecting assessment and learning. High quality feedback identifies strengths, highlighted areas for improvement, and grades future development. Without feedback, assessment loses much of its educational value. How do we structurally guarantee that the exam is fair and valid? We use an assessment blueprint. Think of a blueprint as a highly detailed matrix or map. On one axis, you list your co-curriculum learning objective. On the other axis, you list your specific assessment methods. This metric ensures that the major clinical competency is intentionally tested and it completely prevents construct irrelevance, which happens when an examiner tests an obscure, low-priority topic just because it's easy to write an MCQ about it. A rigorous blueprint ensures that the weight of the exam perfectly mirrors the real-world clinical importance of the topic. As an example, if your curriculum spends 40% of its time teaching cardiovascular disease and only 2% teaching rare tropical skin infections, your exam blueprint ensures you don't accidentally write a test where half of your questions are about tropical skin infections. It keeps the exam proportional to what matters. Modern curricula require deliberate assessment planning. Educators should preserve the strength of traditional assessment while integrating innovative methods such as OSCE simulation, WPBA, and portfolio. Assessment blueprints ensure adequate sampling of competency and help maintain fairness, transparency, and accountability. To maintain the integrity of our assessment architecture, we must apply data science. This is where psychometric comes in. After every major examination, we must run statistical analysis on our questions. We look closely at two numbers. First, the difficulty index, p-value, which tell us what percentage of students got the question right. If 99% get it right, it's too easy. If only 5% get it right, it might be poorly worded. Second, and more importantly, it is the discrimination index or R point biserial. This mathematically measures whether a specific question can differentiate between high-performing students and struggling students. If top students are missing a question, while struggling students are guessing it right, that question has a structural flaw and must be thrown out of our question bank. For example, imagine an MCQ question with a double negative in the sentence. Top-tier students read it carefully, get confused by the grammar, and pick up the wrong number. Struggling students guesses randomly and get it right. Psychometric analysis flags this anomaly immediately, allowing the exam board to remove the unfair questions. Next is the standard setting. that we call as defining the line of competence. One of the most legally and educationally sensitive decisions we make is deciding whether the pass line sits. Historically, institutions use an arbitrary fixed pass mark like a flat of 50% or 60%. This is highly unscientific and dangerous. Modern assessment utilizes formal standard setting methods such as the Ankoff method for written examination or the borderline regression methods for OSCEs. These methods gather a panel of clinical experts to analyze the actual difficulty of the specific exam items and define what a minimally competent, safe practitioner should score. This ensures the pass mark shifts dramatically based on how difficult the test actually is rather than a rigid, arbitrary number. As an example, if an exam happens to be incredibly difficult one year, a rigid 60% pass mark might unfairly fail excellent students. If the exam is too easy the next year, 60% might let an unsafe student pass. Standard setting adjusts the pass line scientifically based on test difficulty to ensure safety remains constant. Next, I would like to talk about is the human factor. How to overcome these biases in subjective evaluation. Let's look at the three most common bias. This is a halo effect occurs when an examiner likes a student's confident personality or neat appearance and unconsciously gives them a higher score on their clinical skills. Next will be the central tendency bias happens when tired examiner avoid giving very high or very low scores, safely marking everyone right down in the middle, which makes which marks excellent or failing behavior. And finally, the Hawthorne effect. This happens on the student side when the students know they are being actively watched during a workplace-based assessment. They perform flawlessly, which might not reflect how they act when unsupervised. We mitigate this human factor through continuous examiner calibration and anonymous grading systems. For example, an examiner might think this student spoke beautifully and looked very professional in their suit, that we call it a halo effect. So they unconsciously give them a passing grade on a physical exam station, even though the students actually forgot to wash their hands and missed checking their patient's pulse. This slide summarizes assessment approaches across cognitive, psychomotor, and affective domains. Knowledge is typically assessed through written examinations because they are efficient, economical, and reliable. Skills require direct observation through OSCE simulations and practical examinations. Attitudes are the most difficult to measure and often require longitudinal observation, reflective writing, and multi-source feedback. A useful example is professionalism, which cannot be accurately captured in a single test but emerges through spread observations over time. Here we see specific assessment methods matched to educational objective. Knowledge-based objective may be assessed using MCQs, essays, short answer questions, and oral examinations. Skills objectives are best evaluated through OSCE, practical examinations, and simulation. Attitudinal objectives require reflective journals, portfolio, peer feedback, and professional behavior evaluations. Selecting the right assessment method is critical for obtaining meaningful results. Furthermore, learning analytics and artificial intelligence are beginning to track a student's daily interaction with electronic health records. AI can analyze clinical reasoning patterns in real time, identifying cognitive fatigue or diagnostic errors before they ever reach a patient's bedside. Technology will allow us to make assessment continuous, invisible, and highly objective. Imagine an AI system running in the background of a hospital ward. It tracks how many diagnostic tests a resident orders. If the AI notices the resident consistently orders excessive and unnecessary CT scans for simple appendicitis, it flags this learning gap and automatically assigns them a targeted learning module. Then we would navigating the legal and ethical boundary of our assessment. When designing an assessment architecture, we cannot ignore the legal and ethical boundaries. We have a strict duty of care to these distinct groups. First, To our patients, we must guarantee absolute patient safety and strict confidentiality, especially when using real clinical cases or recording student-patients interactions. Second, to our students, we must ensure equity, fairness, and absolute transparency in how they are graded. If a student fails in high-stake exam, our rubric must be legally defensible, showing no signs of discrimination or examiner bias. And third, to the public, as medical educator, we act as a societal gatekeepers. Passing an incompetent student out of sympathy is a severe ethical violation that puts public health at risk. Our assessment blueprint is our legal and ethical shield. For example, if a medical student fails in a clinical exam and launches a formal legal appeal against a university, a clear, pre-published blueprint and standardized checklist prove that the student was evaluated fairly against objective criteria, protecting both the faculty and the institution. To conclude, building an effective assessment architecture requires us to understand our practical trade-offs. Knowledge assessment via written exam is highly reliable and cost-effective. Hands-on clinical skills require direct observation through OSCEs and simulation, which increases resource costs but provide true behavioral insights. Professional attitudes and values are the hardest to measure but can be successfully captured over time using continuous feedback loops and workplace-based observations. By thoughtfully combining this traditional and modern framework, we ensure that our medical institutions graduate clinicians who are safe, deeply competent, and fully prepared for real-world practice. The references presented here provide the evidence base supporting modern medical assessment practices. To wrap up our entire lecture, let us remember that no single assessment method is perfect. The secret to building a world-class medical assessment architecture lies in triangulation. We must combine highly feasible written exams for one core knowledge, highly reliable OSCE, and simulations for practical skills, and continuous workplace-based assessment and portfolio for professional attitudes. By balancing the four forces of validity, reliability, feasibility, and acceptability, we protect our students, our institutions, and ultimately the lives of the patients we are trusted to serve. On the final slide, I have included the key academic literature and foundational references that support these frameworks. Thank you so much for joining today. I wish you all the best in your future educational endeavors.